Well, thanks everybody for joining. So this is the healthcare work group of the Governor Mills AI Task Force, as you all know. And I think so, the work group itself is fairly small. So I think we actually have most folks here. And then we have several invited guests. And then we have our trusty and hardworking, as you heard, GoPIF support staff. So why don't we go around though, because I'm not sure that everybody knows. And I'll just call off as I see folks on the square. So I'll start with Mary.
I'm Mary Dickinson, and I am unfortunately on the move in New York City at the moment, but really excited to see what everybody's going to say today. I am the Chief Scientific Officer at the Jackson Labs and the co-chair of the AI Task Force. So, pleasure to meet everyone.
Great. Well, thanks for joining, even from the road. So thank you. Chris.
Hi, everyone. I'm Chris Mallett, the Chief Administrative Officer of the Rue Institute. It's good to be with you again.
Great. And Dan.
Hi, everybody.
Dan Nygren.
Sorry, multiple Dans. You go ahead.
Oh, sorry, Dan. Sorry, Dan N. Sorry.
Yeah, I'm Dan Nygren, the Chief Information and Digital Officer at Maine Health. I'm also a physician by training.
Great, thank you. And then our guest, Danielle.
Hey, y'all, Danielle Louder with MCD Global Health and the Northeast Telehealth Resource Center. Joining as a guest, as Lisa mentioned, we provide training and technical assistance to folks all over the region. So just really wanting to be looped in and see how we might be able to help this effort and also help others throughout the region to replicate what we're doing. Thank you.
Great. And Bryn.
Hi, I'm Bryn O'Neill. I'm a regulatory policy specialist with National Nurses United and the Maine State Nurses Association.
Great. Bryn, just out of curiosity, are you here in Maine or?
I am not. I'm based in California, but we represent 4,000 registered nurses and healthcare professionals in Maine. And I work closely with Koki Giles, who's the Maine State Nurses Association president.
Okay, great. And it's early there, so thank you for joining. I didn't realize that.
Yes.
Sue.
Morning, everyone. Sue Woods. I am trained as an internist, health service researcher. I've been a consumer informaticist for over 20 years. Spent many years at Maine Health and more recently at the VA at the national level, where I was director of patient experience for their digital health office.
Great. And from GoPIF, Dan M.
Hi, everyone. I'm Dan Matz. I work as a policy and data analyst within the Governor's Office of Policy Innovation in the Future. One of the lead staff making sure that this task force runs as smoothly as we can possibly manage with everything we've got going on. Good to see you all.
Great, thanks. And I neglected to introduce myself, Lisa Letourneau. I'm also an internist by background. I've done more public health and quality, currently serve as an advisor in the commissioner's office here at Maine DHHS, where I share a seat or back up Commissioner Sarah Gagne-Holmes, who's often got multiple commitments, so she's not able to be here today, and have been helping to facilitate this healthcare work group. So thanks again, everybody, for joining. The goals for today's meeting are really to keep in front of us the overall charge and process and timeline for this work group. So Dan Matz is going to remind us of what that is and orient some of our guests to that. And then hear a couple of different perspectives that we haven't specifically had a chance to bring in yet. So first from nurses, and more specifically from National Nurses United. Bryn and Sam Boss from the task force had connected us with Bryn, and so she's going to do that. And I'm not seeing Sam on. Do you know, Bryn, was Sam planning to join today?
I do not know, sorry.
And then patient perspective. So Sue Woods, as she mentioned, has done a lot of work on participatory medicine and had a great article and I posted both the background documents, the Nurses and Patients Bill of Rights, and then the journal article from Sue Woods on patient engagement and what that means in the era of AI. So We don't have a ton of time, but I appreciate both of them being here to share perspectives from those fronts, and then really digging into the work of this group, because we only have now this meeting and one more of this work group to get to some of our key charge and deliverables. So we're hoping to spend the rest of the meeting hearing from all of you thoughts on that. So any questions about the agenda or anything anybody wants to change or add? All right. Well, with that, then I will turn to Dan Matz to remind us of what we are all charged with doing on this work group.
Yeah, great. Thanks, Lisa. So I think just super briefly, I think most of the folks have heard me say a version of this a number of times, but just to make sure we have sort of the big picture in our brain as we get into some of the meat here. Over the next about a month now remaining up until the end of July, there are 6 work groups, this being one of 6 work groups that are doing a version of this process and tackling various topics that the larger task force has decided are sort of the best, the most important ones for us to hit. As Lisa said, we've got this meeting and one other meeting of this group to hash through a number of questions that were sort of approved and decided on by the larger task force, which I will be happy that I can put in the chat in just a second here, just to make sure that we have them all in front of us. And the deliverable at the end of this is to make sure that we have some draft recommendations that our team at GoPIF and working with Mary and David, the co-chairs of the task force, can sort of synthesize and present back to the group at our meetings later on in the late summer and early fall. The only other sort of twist that might be a new piece that just to make sure I say here, and maybe Mary, I'll point at you for a second if you're able to talk, is in talking with our co-chairs, there was an interest in making sure that they are sort of kept up to date on the broader scope of this work. And so just for your all knowledge, we have set up a sort of a briefing for likely Lisa to sort of come in and do a pitch of some of the ideas that are really coming to the surface of this group and have that sort of replicated with all the other groups as well. So that's coming up in a couple of weeks. So there's more to come on that, Lisa and others, but just to let this group know that there's sort of this overarching thesis of PCs that are emerging and trying to sort of stitch a lot of disparate ideas together. Mary, I don't know if there's anything else you wanted to say about the big picture process here. Otherwise, yeah.
Yeah, I mean, I think you nailed it on the head, right on the head. I think that it's going to be important for us to look at the issues that are both unique to each subgroup and cross-cutting. And we hear many themes that are certainly cross-cutting, but so we want to make sure that we can differentiate the things that are really unique to the healthcare unit. I will say that this subgroup is really a priority. Everyone feels really strongly about the work that's going on in the healthcare space in Maine. And so I really appreciate everybody's attention to this and everybody, contributing, because I think it's going to be an important part of the work that comes out of this.
Terrific, thanks. All right. Any questions about that? And I think, Dan, you were going to put maybe in the chat. I haven't seen it, but the overarching questions, and I've got several of them written down at the bottom of the agenda as well. It's actually sort of all of them if you combine a few, which I may have misnumbered. I think it's Q4, but so questions before we jump in? All right. In that case, we'll move on to Bryn O'Neill from National Nurses United and perspectives from the National Nurses Union with the Bill of Rights.
Wonderful, thank you. As you said, I'm Bryn O'Neill. I'm a regulatory policy specialist with National Nurses United, and I work closely with Koki Giles, who serves as the Maine State Nurses Association president and NNU vice president. And we represent more than 4,000 registered nurses and healthcare professionals providing patient care directly in Maine, and also 225,000 registered nurses nationwide. So our basic position is this. We know humanity is at the heart of nursing care and that humanity should never be automated away. nurses' power to use clinical judgment and to care and advocate for patients must be protected in the age of AI. And most researchers and developers you've been talking to will agree. They want their tools to augment nurse skills and other healthcare professionals, but we talk about nurses, not to replace nurses. But we also have to keep in mind all the other big picture factors at play. Tech companies and the Silicon Valley investors are betting on big returns to their AI investment, which, by the way, are really not happening yet. And AI companies' sales pitch to hospital employers is about cutting labor costs and maximizing billing. For example, NVIDIA/Hippocratic AI have been marketing AI agents explicitly as $9 an hour replacements for nurses. And then there's the workplace contexts and systems in which AI is deployed. Last year, NNU surveyed over 2,000 RNs across the US, and we found that 60% said they do not trust that their employer will implement AI with patient safety as the first priority. Now, we're not against tech. We've always embraced technologies that augment skills and improve patient care. But time and again, nurses have seen employers use technology to automate, descale, and devalue nurses' work. Promises about new technologies that are supposed to free up more time to spend with patients have, in practice, wound up taking up even more time away from patients. So there's a role for AI in healthcare, but we need to ensure that AI works for nurses and patients by implementing sensible regulations and ensuring that nurses and unions have a meaningful voice in whether and how AI is implemented. So just to back up, we'll do the what is this quickly, because you all know, but most of the tech we talk about as AI in healthcare is in two broad categories, predictive AI and generative AI. And predictive AI has been around for decades in healthcare, clinical decision support systems and EHRs, for example, acuity tools. So we have means to predict what we're going to see in rollout from what has already been happening. And we also now have the generative AI built on large language models like ChatGPT, including the ambient scribes you've already talked about, and chatbots that draft responses to patient communications, for example. And both types come with limitations and risks. They're subject to the garbage in, garbage out principle, so their outputs will reproduce inaccuracies and limits in both training and input data. For example, in our survey, 2/3 of nurses said automated acuity scores that come out of AI systems do not match their own assessment of the patient in front of them. And that results in staffing recommendations that can underestimate the care that patients need. There's also the problem I'm sure you've all heard about of algorithmic bias, where AI systems reproduce race, gender, and class biases encoded into training data. And then Gen AI has new challenges, like the tendency to hallucinate. I heard one example from a primary care physician in state safety net facility in California. He was using an AI scribe in a visit with a patient living with HIV. And the patient told the doctor he'd been out in his yard and cleaning up some pine needles and got scratches on his arm. And the AI scribe heard needles and arms and undoubtedly HIV and fabricated a history of intravenous drug use in that patient's record from nothing. We can also see omissions of critical information from generative AI. One of our nurse leaders in Lansing, Michigan, had an experience where an AI-generated handoff report left off the fact that his new patient was COVID positive, which he only realized after entering the room without the appropriate PPE. So, industry's response to these flaws in LLM-driven AI is to say there should always be a human in the loop to verify their accuracy. Sounds reasonable, but in practice, it puts nurses in the position of having to constantly fact-check the tech that was supposed to make their jobs easier. And that extra labor can wind up negating any time the AI was supposed to save. That's what studies have shown in some facilities where ambient scribes and Gen AI patient communications have been piloted. But the bigger risk is that nurses working in understaffed facilities under real conditions with managers will be pressured to rush through fact-checking AI output. And that creates an environment that promotes automation bias, assuming an AI system is correct and not checking for errors, which can have deadly consequences in healthcare. For example, we asked nurses about the planned Maine Health Abridge pilot, which you've heard about. We heard that doctors there have already been using a tool called Haiku for years to transcribe dictation without the AI summary component. And nurses described these dictations as riddled with errors and said they already spend a significant time asking doctors to review their own discharge instructions because the doctors do not consistently proofread their own dictation. Because they're doctors in the ER, they have a lot happening. And this leaves the nurses concerned because AI summaries aren't just going to look like garbled dictation, they're going to look right. That's what they do. They look right, often more right than the facts in the world, which are a lot messier than your sort of average probabilistic text. So there's risks in having summaries that sound convincing but have significant inaccuracies and relying on busy doctors to catch and fix those errors. So getting AI right in healthcare is very difficult. In the last subgroup meeting, you heard how some of the complications of trying to responsibly design an AI tool for mental health and all the times in which they had to turn around and say, oh, can't do it that way. But in the absence of regulation, you don't just get those researchers. You get cases like the National Eating Disorders Association, who laid off their helpline staff after, by the way, they tried to form a union, and replaced them with a Gen AI chatbot that pretty quickly started encouraging dieting and disordered eating behavior in the people talking to it. And even tools that work at first can have their effectiveness decline in surprising ways over time. So, all that in mind, what can you recommend as a task force? Basically, we need strong regulation of AI in healthcare. In the US, there's a regulatory vacuum right now, at least when it comes to generative AI. There's almost no transparency, no pre-market testing and approval requirements, no standards for measuring clinical efficacy, and no post-market monitoring of errors and adverse events. Our union believes we need a regulatory framework based on the precautionary principle. We need to put the burden of proof not just on AI deployers like hospitals, but also the developers to demonstrate AI is safe, effective, and equitable before it is implemented in real-world healthcare settings. And finally, it's crucial to focus not just on minimizing AI risks, but protecting the rights of nurses, patients, and the public in the face of AI. So we've developed, to help do this, an AI Bill of Rights that guides our advocacy work. And that includes the rights that you see a lot in tech regulation, like the rights to safety, privacy, and transparency, but also the right to high-quality person-to-person care, the right to exercise professional judgment, autonomy, and the right to collective advocacy for workers and their patients. And you all have a copy of that in front of you with a little more detail. So I will just touch on them briefly and then let us get to the discussion. So safety is what I've already talked about. Testing and ensuring safety and efficacy before deployment. The right to high-quality person-to-person care. Patients have the right to in-person healthcare based on their needs and their wishes as individual people provided by skilled and licensed healthcare professionals in the appropriate settings that hasn't been compromised by worker displacement and de-skilling. Privacy includes limitations on data collection and use. Transparency has both privacy and safety aspects. Workers and patients have the right to know what info is collected and what's done with it. And also, patients and professionals have the right to see what the evidence and rationale is underlying recommendations that are guiding care. The right to professional judgment. Nurses and clinicians have the right to exercise the professional judgment they're trained for and to override decisions that do not make by an AI. that don't make sense for a particular patient, with the threat of discipline or discharge, and with enough time to, consider their clinical decisions. Autonomy, the right to refuse to be surveilled or to, as a patient, have treatment rely on AI decisions. And finally, the right to collective advocacy. Union workers must be able to bargain over whether and how tech is implemented and to understand how decisions governing their working lives are made. So they're not subject to management based on computer decisions that they can't see the evidence for or refute. So that's a lot, but I know we don't have a lot of time. So I'm happy to answer questions going forward. Thank you.
Yeah, so thanks very much, Bryn. Would open up for a few questions now. I mean, we also have time again, at the end to talk about some of the issues, which includes patient protections or protections and risks. So we can always potentially come back to it then as well. But any initial questions?
I just thank you, Bryn, first of all, for presenting all of that. I'm curious, as opposed to or in addition to the regulatory aspect that you propose, how should we best approach this? So obviously, as you heard, I'm from Maine Health, and we do want to try and utilize AI in the nursing space. We involve nurses in all of our decisions, and not just management, frontline nurses who are going to be using the technology to inform what we deploy, how we deploy it, etc. Is that the best way? Is there some other approach that you that your group would propose? Because I think the regulatory side of things will take some time. I think we're also in an environment at the federal level where we're looking at less regulation in the AI space. I think you can appreciate that. So I'm not sure that that's going to find a lot of foothold, whether locally or at the federal level. And so I'm just thinking, in the absence of that, until we get there, if we get there, what are some other approaches that we can take to deploy this responsibly in the nursing space?
Sure. So part of it is we do like to question the idea that we have to deploy or rush things to market when we don't have that sort of framework in place. But also we, in several of our contracts, have bargaining over tech implementation, and whether or not it's in the contract, we have a lot of experience with this around the country, and being able to sit down with employers, as individual workers and as a union, and talk through, this is the vision for this is what it's going to look like in the pilot, but nurses have seen the last 1,000 versions of the greatest new thing, and here's what it's going to look like on the floor when you have a lot of patients, when you're dealing with a doctor who has no time. And, there's a lot of differences there. So part of it is working through, how are you actually going to have time to review? How are you supposed to know if something's wrong in the orders, if it sounds right? And that, know that you need to get the doctor to review it, or dream of dreams, make sure the doctor reviews everything in the first place. So, being able to sit down in the facility with the union and talk about what this is all actually going to look like. And then, we also like to see testing, studies on the patient care impact. A lot of the time with these tools, it's easier to do kind of provider satisfaction, and we care a lot about whether nurses are satisfied, but we So know that that doesn't always fully explain, the patient care impact. Patient satisfaction too is one thing, but you don't see everything that goes into what the actual care outcomes will be. And then, it's also very important to be bargaining and be transparent about what information is collected and what is done with that information, because a lot of what we talk about as patient care tools are also pretty comprehensive systems of worker surveillance every moment of every day in the workplace. And they're not particularly reliable in many cases. We've seen with, previous technology, people get in trouble for not washing their hands, which would be fine, except for they did wash their hands. The tool just doesn't work.
All right. Well, thank you for that. And again, with apologies that we just kind of have a tight timeline. I think we will move on, but you're certainly welcome to stay on, Bryn. These meetings were all public and happy to have more discussions about risks and concerns later on the agenda. But with that, I'm going to move on to Sue Woods to talk from the patient perspective or thinking about the role of patients in implementing AI. Sue.
Thank you. Thanks for inviting me, Lisa. I have my patient activist hat on. Even though I've been a clinician and a researcher and an entrepreneur for a long time, I've really been driven by patient experience, caregiver experience, and public sort of information. So bottom line, there's never been a better time for the public, patients and the public to be involved, to have their not just their voice be heard, but similar to what you have been talking about, Bren and Dan, is actual hands-on involvement and participation and contribution. So let me just, and I think that's the good story here. What I'll do is I'll just give a brief sort of snapshot about what the public knows about AI, what the public and patients are doing with AI, and then talk a little bit about what they think in the context of what's happening in the world. So most people, and I'm using all the evidence that is available today that is pretty recent, at least within 8 months. So most people know about AI. They don't know deeply about what it is and isn't, but they know the term, and they know 50 to 60% of people say that they're interacting. This is the general public with AI on a daily or weekly basis. When asked if they see a vision where it's going to benefit them, the majority of people do believe that it will benefit them personally. Interestingly, men more than women. I've been sort of scratching my head about that, trying to figure that one out. But Pew Research did a very, I'll put the link in the chat, but they did a very detailed, very large, nationally representative survey about 8 months ago. But most are concerned. 9 out of 10 people are concerned. They're concerned about job loss. They're concerned about the wrong data. They don't call it bias, but people know they've been using the internet for a long time. So they know that not everything that they get is the right information. People understand that. They also are concerned about misusing their data. And they do have some very interesting views about the whole sort of impact on socialization and personal relationships. And there's some much more detailed information that I'll leave in the chat. In terms of their use, the data shows anywhere between 35 and it's going up sort of monthly. Up to 50% of people are actively using LLMs. ChatGPT seems to be the most common, followed by Gemini. Of the people who use it, the great majority find it helpful. About a third say it's very helpful, and then about half, another half say it's somewhat helpful. Very minority of people who are using it say that it wasn't very helpful. When you see what they're using it for, they're using it for personal reasons. If they feel that it's making them more creative, if they feel like they're learning, it's helping them brainstorm. They do feel that they're more productive, although they also say that they feel lazy using it. So there's a really interesting sort of insights that people are gaining as they use it. As you can imagine, most people are using it to search, but they're also using it to plan for things like personal travel and social activities. People in general, huge majority of people say that it will change how people work, and it will change how they also play and do recreation too. So in general, most people really are understanding this more than we might give them credit for. Moving to patients, the big sort of super users, as you can imagine, are the same super users that have been using the internet and each other and peer-to-peer online support since it's been available, which is undiagnosed and rare patient communities. These people are blogging and having incredible sort of experiences and sharing their experiences, finding, obviously it's anecdotal, but finding diagnoses, that they really have after seeing, 5, 6, 7, 8, 10 clinicians. And they share that information. The interesting thing about what's allowed people to do is, people have medical conditions, serious medical conditions. They have a lot of issues, not just the medical, medication, treatment, their lives. So they're using it for their entire lives. They're using it to deal with legal issues, for financial issues. And we know financial toxicity is the #1 reason for bankruptcy of the public. For a medical reason is the #1 reason for bankruptcy, unfortunately, in this country. So people are using it to help solve their life problems, which again, I see it as a super positive opportunity because healthcare can only do so much. So this is a tremendous opportunity for people who are really trying to navigate and have tremendous burden. Caregivers are using it. Remember, it's not just those patients. In the healthcare system, they want visibility and trust, very much like what the nurses want. In fact, there is a group called the Light Collective. It's a patient advocacy patient group that's been meeting for some time. They created AI rights for patients. That's a line. I'll also put that in the chat. Very similar to what we just heard from Bryn. But they want visibility. They want to know when AI is being used. And for things like secure email responses, for example, they say most of the time the messaging is fine. Sometimes there's even more empathy. The AI can actually provide more empathy and more information than the clinician or the clinical team member that's responding. But they also say they can't tell. And that is a problem. If they can't tell if it's a human and they can't tell it's an AI, that's an issue because that'll lower their trust. I think that's a really, Dan, I see you shaking your head. So that's like, put a pin in that one because I think that's super interesting. You don't want to just maintain their trust. You want to increase it. And I think AI and how we approach AI and the relationship between people and the AI, clinicians and the people is going to be really important. So they see these, they do love the idea of clinicians not spending as much time on their computers. So if there's AI that increases efficiency on the clinical team side and they're able to spend more times face-to-face with their clinician, whether it's video or in person, that's a huge thing. And it's really the next sort of generation or the next sort of step beyond open notes. So I had the privilege 11 years ago of leading the open notes for the veteran across the VA. And there's plenty of research on that. And what we learned is that people really do gain confidence and from that information, and they come in with better questions and better ability to take care of themselves. So what patients and advocates really want is to have these tools, give them more time with their clinicians when they're actually interacting, and B, allow that relationship to be equal. So it's okay for the caregivers and the patients to be using this information, so they want to be respected for it because they are in charge of their own lives and they want to be able to co-pilot. And so, I mean, that's a little bit of where the tension comes is for, I mean, as a physician, you know, you always want to sort of control things, but the reality is the more you partner and guide patients and their families, the greater the trust you have and the better outcomes they have. Just a thought about digital divide, because the concern is always when we, you know, when digital health has come and there is a digital divide, but what we've learned, it's not about age or economics. It's really about access to connectivity. And I'm glad you're on here, Danielle, because it is all about connectivity, which does have affordability component to it, but a lot of times it's more of a geographic thing. And you know, most people have smartphones now, and those smartphones have AI-enabled applications. So it's going to be much more accessible to everyone. And I'll just put a plug in again. We do need cellular in the state of Maine. We need both. We need Wi-Fi and we need cellular because most people are mobile. Most people are getting information, including search and AI on their mobile devices. So smartphones will narrow the digital divide. Where we will have a divide, however, is in information. Why? Because, well, we know that there's bias in information, but the thing that we tend not to think about is paywalls. So the public doesn't have access to a lot of publications and evidence. There might be proprietary reports, obviously, that they're not going to have access to. So there is a little bit of actually not a little bit, because patient advocates complain about this a lot, not being able to access evidence, because they want that evidence, because now they can throw the papers into an LLM and get a very laid, simple summary of what that research means. I mean, you can throw a paper in and create a podcast on a paper. It's incredible. Okay, so just my last comment is about co-design. So we know that from decades of research that patients, not just as focus groups, but as participants and contributing to whether it's, you know, ideation, prototyping, testing, or implementation. We know every part of that development journey is really important. We're going to be publishing, by the way, the Journal of Participatory Medicine, where I just stepped down as editor-in-chief after 9 years. We're going to be publishing about 10 or so papers. Several of them are from patient advocates, but one is going to be about pre-med students who had patient advocates come in, and they had like aha moments where when patients and advocates and caregivers were talking about what they do in their lives and using AI, it really opened up their eyes. So again, I would just say, summarize by just saying people are using this probably more than you imagine. It's really helping them not just for their clinical issues, but their life issues. They have the same concerns that we all have as professionals, particularly around visibility. There's a significant opportunity to increase trust, not decrease it. And I think that, you know, the more we do to promote people using it for their own purpose to help them co-solve issues in healthcare, the better we're all going to be. Happy to answer questions.
Great, thanks so much, Sue. Really helpful. Questions for Sue, and again, you can have more time later on in the general question discussion, but questions.
So this is the Pew study, and there's also a more recent one. Elon, does anyone know where Elon University is? I have no idea. And
It's
then,
It's in the Carolinas,
North
right?
Carolina or
okay,
something.
Carolina.
yeah, they're doing, well, what's his name, Lee Rainey, who used to run the Pew Research Center, is now at Elon. So those, I just put 3 links in.
Great, thank you. Questions?
Quick
Dan
question.
M.
Yeah.
Yeah.
I'm wondering if there are like, I mean, I coming from the state background think about states, but whether it's municipalities or states that are operationalizing some of these ideas, or thinking about if there are sort of exemplar places that we could look to, or if this is pretty sort of cutting edge. I know the technology is still sort of relatively new, but just always looking for places that we can poach.
At the state level, I don't know. I think that's a great question. I mean, there are national groups, obviously, but I can sort of put my feelers out and get back to you about that.
Yeah, I feel like in our region, there's not necessarily, I feel like Maine is kind of leading some of this stuff, honestly, but I think, as you mentioned, it's going to be probably the systems and national organizations that are probably going to get out ahead of it first. But yeah, there's so much going on in this space. And just to comment on the connectivity, Sue, wholeheartedly agree. But we also know that, you know, Maine had $35 million in digital equity and inclusion funding coming to us, and the current administration has disassembled the Digital Equity Act. So, and they have totally revised. We'll still be getting BEAD money, which is the Broadband Equity Access and Deployment Program. But as we know, this administration has a real issue with the equity part of that. So we're just now calling it the bad
Yeah.
because it's taking out the equity. Yeah. So what we're seeing is that they're still going to be able to disseminate funds throughout the state for infrastructure, for example, and some of the digital opportunity, which is kind of some newer language that we're using to fit in with the executive orders and whatnot. But they're taking out some of the previous sort of guardrails that would have focused on affordability and accessibility. So they're kind of letting the internet service providers off the hook, if you will, with respect to that affordability side of things. And the rural, I think, will still be supported. But yeah, it's going to be interesting as the guidelines sort of shift and change in the moment and how states are responding to that.
I mean, again, in terms of internet access for the public, it's much better than when sort of things like when patient portals first rolled out. So when we first rolled out My Healthy Vet portals at the VA back in 2008, sorry. You know, every VA has to have a public computer. And we know that people go to libraries or people go to other people's houses. A lot of people just use their smartphones. So I do think the access to this, that digital divide is going to be more narrow. But like most things, it's the capacity of what people do with it, you know, what they know they can do with it, or what the potential risk might be. So I think anything we can do to help the general public and patients and caregivers to understand. You know, when we first rolled out, I'll just say, when we first rolled out email at the VA, we looked at the variation at the provider level. We took a bunch of providers and looked at the percentage of their patient panel that were registered, and it varied like 8-fold. And it had to do with whether the clinical team brought it up. And the one, you know, so we do have a huge influence on saying what's okay for people to be doing. Because a lot of people will come in, they won't talk to you about the fact they've been on the internet because they're afraid they're going to get, you know, hammered about, oh, don't go there. But I think that's the wrong approach. we should flip that on its head.
All right. I have one other request, Sue, and you mentioned an AI rights or Bill of Rights for patients. I think you were going to put the link for that as well. That would be helpful. Thank you. Whoops, you muted yourself. Sorry.
Sorry, I put the link for the Light Collective. I'll put the link for the actual document.
Okay, that'd be great. So it's from them, I see. Yeah, okay. Super. Well, thanks so much. And certainly another really important perspective for us to keep in mind as we move forward. And with that, I'm going to propose that we move forward to talk about some of these key guiding questions that we've been charged to address. Starting with number one. And for each of these, and again, I sort of grouped them up. Two, I grouped with question, I labeled it wrong, but no, that one's right. Q5 with risks, and then three, innovation, grouped with the general innovation question that all of the work groups have. But so to start with number one, and then I'll try to sort of keep time as much as we can to these three. And then again, we have one more meeting to then come back and try to, so this is still maybe in expanse mode, but then we come back and narrow it. Where does AI offer promise for addressing Maine's healthcare challenges? And are there barriers to adoption that state policy could address? And I'm just going to start each one by giving a brief reflection on what we've heard in some of the previous meetings, both in the broader AI task force and the meeting we had that was focused on healthcare a meeting or so ago, and then in the first meeting of this group. So just synthesizing from some of that, I would say some of the early reflections in terms of ways that AI could offer promise to address challenges. I think number one would be to assist or support the workforce. Particularly, we've heard providers, particularly primary care providers, and the challenges that we have right now in the primary care workforce. And secondly, rural providers, be they primary care, specialty hospitals, or otherwise. And I think some of the specific examples we've heard around that are ambient dictation or ambient documentation and decreasing administrative burden in various through various ways. But so those are the big things I think that I've heard. But what do others think about those ideas or additional ones?
Yeah, from my perspective, Lisa, I think you hit the nail on the head with both of those. Those are the two that came to mind for me as well. Just the support for the workforce, in particular, where we've got shortages of various roles within the healthcare ecosystem. I think these technologies are going to help. And then for the rurality of the state and the various means by which we've all talked about where AI could be helpful in addressing some of those challenges.
Others.
I think so too. I was looking for a graphic that we presented in this healthcare AI boot camp that I shared in the link earlier.
Can you just speak to that briefly,
Sure.
Danielle? I was intrigued with the 300 participants, but yeah, folks don't know about that.
Well, remember, it's national too. So this is a group of all the telehealth resource centers across the country, sort of initially fueled by our colleagues in California, the Telehealth Resource Center. So we've all been helping promote it. So it's a boot camp. It's a series, a summer series. It kicked off yesterday, which was kind of high level definitions. I learned stuff, guys. Our experts at the Telehealth Technology Assessment Center, who are big time geeked out on AI, both the positive and negative aspects of it, right? We have to be very careful. Had some great information. And then our colleague, Elizabeth Kropinski from Emory University, and she's the PI for the Southwest TRC, has been studying human factors for a very long time. And now she's kind of applied that to the utilization of AI in healthcare. So it's a great session. I'll make sure they should be posting the recording and the slide deck very soon to the website that I shared. But the next one, there's one per month, so you can kind of get caught up. But I think legal and regulatory considerations are going to be the next focus area. So on July 23rd. So I'd encourage you to share it widely or participate yourself. There's some really great information being shared there. But this this graphic, if oh, I can't share it, but I'll put it in the chat.
Yeah, Dan can give you access.
Okay. Okay. The FSMB actually provided some recommendations, and you probably have already seen them, or especially the Maine health team that's been looking at this, and Dan too, a lot lately, that this kind of jives up with what we've been talking about in sort of the initial use cases. I really like it because we're talking about both risk to patient safety and how it explicitly impacts the practice of medicine. So you can see, administrative task has the least impact on both. And that's what we've been talking about, how to use this to increase capacity of our clinicians and other team members to, best manage and treat patients. Data collection, documentation, and scribing, which kind of falls, it's still in this lower third of the impact, and then all the way up to clinical decision support, which obviously would have the most impact on both risk and the practice of medicine. So this just seems like a great guideline, and I think what we've been talking about here in Maine kind of aligns with this on what we think are the sort of no-brainer use cases, and what we know we want to be much more cautious with. So anyway, I can share this in the chat.
Great, thanks. Chris.
Danielle, I think that image that you just shared is really powerful and helpful. And I would just say to others on the subgroup here that we might want to think about using something like that as an organization framework for some of our ideas. Not to repeat what Danielle just said, but it takes some of the guidance that our guests have just given us, Bryn and Susan, and I think it puts it for me anyway, it puts it in a position of, how do I say this? I believe that there are certain things that are relatively straightforward that can be handled. And that chart, bottom left, sort of demonstrates that. And then increasing sophistication, increasing care, increasing pace, maybe slower pace, deliberate, more debate, discussion, et cetera. But I think it's important that our recommendations as a subgroup, challenge the governor and the state to really embrace this opportunity, because I just can't see a future that isn't increasingly tech enabled, and especially in really complicated environments like healthcare and other places where it's very, very hard. The promise of technology is that it can help. And so I think we should be mindful of, the guidance that our guests have given us today, but we should be deliberate and proceed. And that framework, to me, gives us maybe a roadmap and the beginning of like some guidelines with increasing scaffolding, I suppose, as you go up and to the right.
Yeah, I'd echo that as well, Chris. And I think the reassuring thing is that for organizations, not just here in Maine, but in talking with colleagues around the country, the reassuring thing is that that's exactly how we've been proceeding, because I think everyone appreciates that we've got to be cautious. We've got to get our feet wet on administrative things where if something goes awry, you've not impacted a patient or their care. And we'll learn as we mature and progress and the technology improves. And as we do that, we'll gradually make our way up and to the right.
Great. Just a last minute or two on this one for now. Are there barriers to adoption if we think about even staying on that left-hand side of the graph? And Bryn, I see your hand up. Not sure if it was in response to that or not.
Yeah, that was in response to the previous discussion. I don't know. Just wanted to raise a little note of caution on that graphic and the notion that documentation is low risk, because think about that ED context where I was talking about with the dictation tool. Dictation is, notes, but that turns into orders, which, a nurse is supposed to be checking, but AI makes everything sound good. When I type something to Google now, I get an answer that sounds great, whether or not that information actually exists in the world. So documentation can be very high risk. That also turns into our nurses have been asked to do handoffs in hospitals from one nurse to the next nurse taking care of a patient. All best practices say that needs to be a discussion face to face between two people. Some hospitals have asked nurses to substitute that with an AI generated report. And that's where you get that nurse walking into that COVID positive patient's room without any PPE. So there are very significant risks in that documentation bucket.
Yeah,
I would
yeah,
definitely
yeah.
agree, but I think it's just like anything else. And this could happen with in-person care. It happens with telehealth. And like, how many times with COVID have we had to help people fix sloppy telehealth, right? If they didn't set the correct parameters or guardrails around it, you're going to get that. So I think that's why we have to have folks like you around the table, Brian, when we're setting these guardrails, because we know we're not going to get it at the federal level, as we've talked about. Nothing about us without us, right? It should be a tenet of everything that we're doing. And I think Dan Nygren can talk to it, but I was amazed when we did a set of demos of how Maine Health is using AI and just the checks and balances. So the patient and provider satisfaction was through the roof, but they're tracking on an individual level. The accuracy, specificity is another key. Like accuracy is great, but we also need to talk about specificity with AI. And they're tracking that to ensure the safety of the documentation. So anyway, just wanted to.
Well, let's also just, I mean, humans are humans. We make mistakes as well too. I mean, the quality assurance and the ability to infinitely sort of check, double, triple, quadruple check using technology can dramatically mitigate risks relative to just human error, right? Conversation is wonderful, but if one person in the thought partnership is not trained well or not having the best day or makes mistakes, that's equally problematic. So I appreciate, Bryn, the caution, and certainly we respect it fully. I'm curious to know if your group are you seeing pockets of technology that excite you, that you're very sort of you think are representative of the future and opportunity here, or is it the position of your organization that technology really isn't appropriate for healthcare?
Well, nurses use a lot of technology every day. That would be
No, I didn't mean that. I
very
didn't
tricky.
phrase that properly, but the paradigm seems to be like we really shouldn't do much here. That's what I'm hearing. Am I hearing it wrong?
Saying that the structures we have to, make these tools be safe are often really lacking. And, a lot of what we're doing in terms of supporting adaptation is very specific to each facility, each tool. But then we also see things like the EPIC sepsis algorithm that was rolled out in hundreds of hospitals and turned out to be just massively inaccurate, or, had pretty good accuracy when it used the fact that antibiotics had been administered to guess whether a patient had sepsis, which, they were administered because the doctor thought they had sepsis. So we see nurses being asked to, deal with the alerts or have their clinical judgment overruled by these tools that are really not going through the sort of rigorous, in many, many cases, the kind of rigorous testing and verification of safety that the very careful researchers who show up to policy meetings might be doing. So it's not that, we are pro or anti technology. It's that we see how these things work on the ground when you have a boss, when somebody saw a really great PowerPoint presentation at a conference about a new tool, and it gets, shoved out there, that, is not always living up to the promise of what you hear about.
Okay, I'm gonna go back just one step before we come back. So we've sort of, I think, gone on to risks, and then I'd love to hear about thoughts on particular protections. So I think we all agree this is the train's left the station, right? It's moving forward. We have to figure out how to harness appropriately and how to use it to our advantage without it posing undue risks more than humans alone, right? To your point, Chris, are currently also at risk for injecting into the system. But just going back to the opportunities and potential barriers to adoption, I'll also reflect back that what we've heard in previous discussions might be limited resources, particularly in smaller organizations, limited staff. We don't all have a Dan Nygren, unfortunately, staff to either implement, to ensure that things are being done safely. Limited education and potentially, even policies, procedures, or resources to ensure that policies and procedures are in place. Other potential barriers to adoption, still on question one, and we'll come back to the other ones, but about potential AI implementation that would help to address Maine's healthcare challenges.
I think we touched on this a little bit before, Lisa, but I'm wondering if a bit of clarity around patient disclosures and disclosures in general might be helpful, because sometimes I think there's a lack of clarity for how one ought to roll things out, whether it's to team members themselves, to alert them about how we're using AI internally, or if for sure it's a patient-facing thing, what disclosures we might need to make and guidance around how to do that. I don't see it as a barrier now, but it's certainly something that we stumble on and we churn a lot internally and talk through, and we could, if we had a stricter set of guidelines to follow, I think that would be helpful.
Mm-hmm. So that potentially is also going into the question of, are there particular protections needed or risks, and potentially that protection might be developing better systems to ensure transparency and clarity of what is happening. Is that fair?
Agree, yeah.
Okay. Any other thoughts on particular barriers in Maine to adoption of AI? And I know these things kind of meld into each other, but Chris.
Well, I think the things that Bryn is describing are barriers that need solutions to sort of be overcome, right? She's absolutely right. If the technology isn't fulfilling the promise, or if it's making mistakes, then that by definition is a barrier to adoption and the full potential of the technology. So in our first subgroup conversation, Lisa, one of the things that I was struck by was the potential to create what I'll call demonstration sites or experimental sites that are well-resourced, staffed. Maybe they're also the places to implement these Bill of Rights or sort of paradigms that Susan and Bryn were describing and recommending, and use them as controlled places to really push the boundaries of the technology and the testing with perhaps the clinicians who are the most comfortable with ambiguity in technology and who are the most confident in their ability to push back when the technology isn't working. And so I guess I'm not answering your question, or I'm quickly answering it and moving on to what to do about it. But the barrier of inconsistent implementation and variability among the various environments, and especially in a state like Maine with an ecosystem of healthcare that's as diverse and varied from a resources perspective in good ways and bad ways as ours is, could be controlled for, and we could accelerate the adoption and the learning with demonstration sites, smaller networks of healthcare clinicians and organizations working together, but with a tech-first orientation, right?
Yeah, I hear that even as a potential protection against certain risk, right? So controlled pilots to roll things out. So rather than saying everybody statewide should adopt XYZ, that I think you're saying do it in controlled pilots or demonstrations to test things out.
Yeah, it's kind of like the whole. Oh, sorry, Dan. Chris, sorry.
No, please, Danielle, go ahead.
I was just going to say it's kind of like the concept of what we should be asking AI vendors, platforms to do is the whole shadowing idea. We try it in a very controlled way, you know, before we actually launch it and impact real people.
Well, perfect, Daniel. I was just going to say, an expectation and a requirement of a technology partner would be you first have to sort of work out all the kinks and prove the concept in these experimental sites, these demonstration sites. Organizations could even apply to host one, right? Maybe there's some financial incentives available to rural health provider in Maine if it wants to become a proving ground for AI or tech innovation against some sort of criteria. But it could literally be before Dan gets to implement the latest, vendor tech system wide, he's got to implement it in a demonstration site, and the partner has to agree to certain principles or investments themselves, to kind of pilot and test it and prove it out.
Chris, maybe it's still because it's early days, but what I'd say is very practically, that's how it's happening anyway, irrespective of any framework. Because I don't think any health system is going to be comfortable, even if the vendor says, yes, I've tested it in XYZ places. We're sort of taking very cautious baby initial steps. And only when we're reassured of things do we go beyond that. Again, that may change.
But are some organizations not doing it at all because they're not you and they don't have the ability, right?
Yeah, that's true.
Well, and we talked about the importance that these models have been created in more like urban academic centers. How do we make sure that they're going to be appropriate for rural? So maybe we also have to do side-by-side rural, testing and piloting.
Sue.
I think because of the level of use by the public outside healthcare, I think it's important to think about the kind of things that can be done and problems that can be solved that are largely inside the healthcare system, really focusing on, say, professional efficiency, patient safety, or, making sure systematic things get done. But if the problem is, some of the biggest problems we have, like, for example, around mental health, access to care, wait times, think about, what could be done that's in more community-based or community partnership-based, where people are using tools on their own as well. So, and that, I know it makes it a little more, it gives it complexity, but I think I would encourage whatever you do to make sure you don't do it in a vacuum, because what people are doing in their lives, like Lisa said, the genie's out of the bottle, but there's an opportunity there, a tremendous opportunity. There are also some risks. I mean, we're finding about, say, the mental health chatbots. There are real significant risks around people becoming attached and getting, information. But at the same time, those shouldn't be, the risks shouldn't be driving the ultimate goals.
All right, so I'm going to use the last little chunk of time here to move on to the third question, which is, what might it take for Maine to emerge as a national innovation leader on using AI to improve rural health outcomes, which is, again, related to the broader question for all the groups about innovation. So ideas, what would it take? What could Maine do to be a national leader? Danielle is smiling broadly. You have ideas.
Oh my God. Well, I mean, I think to begin with, we're kind of taking it's the heavier lift, but we're looking across sectors, right? With this work, which I think is really important. Obviously, there's different lanes for healthcare versus economic development versus, workforce and all of that. But yeah, partner with the RU. Like we're doing that. But yeah, just carefully thought out, involving all the partners all around the table, those who both are sort of ready to jump in full force and those who are very much reticent to do so. I think that's going to be really important to designing some structure and guardrails that are going to be effective, and could help us serve as a leader in this area. Leading edge, not bleeding edge, I think will be important for us to get there.
Dan M.
Yeah, I guess, Danielle, maybe this is a question for you, but for anybody, I think about the difference in the sort of pervasiveness of telehealth in the post-COVID world versus the pre-COVID world. And it seems like a really natural progression of that movement, that continued sort of activity, to just continue to beef up the capabilities of what is able to be done in a remote sort of way. And if I was if this is sort of where, when I think about rural healthcare innovation, this is sort of a pretty natural place for that to end up, particularly as we see, impacts of federal funding on rural hospitals and the sort of geographic disparities potentially becoming even more stark. And so I don't know what the national landscape is here, as well as I'm sure you do, but I'm also thinking back to what Dan showed us at Maine Health and thinking about some of the remote monitoring and some of the diagnosis sort of assist tools, and thinking about where to put those puzzle pieces all together in a sort of innovation way. So I just want to put out, I guess maybe it's more of a comment or a pressure testing a thought in my brain of like, does the progression here make sense of going from this sort of COVID push for telehealth, the inclusion of new tools that are powered by AI to create a better ecosystem for folks to be able to receive healthcare to receive access to healthcare in a way that they don't have to leave their communities. Does that, Danielle, what is I guess I'm looking to you for what the national conversation is like on those subjects.
Yeah, and a lot of the AI use cases that we've been talking about that are kind of the no-brainers aren't telehealth, but absolutely it is being integrated into remote patient monitoring is probably the biggest use case. And there's a lot of specialty RPM use cases that have AI embedded kind of from the get-go, and leveraging that data to triage resources, very limited resources like, cardiovascular services or nurses that aren't having to travel to people's homes for their congestive heart failure, because they're tracking their data very effectively and identifying those who are at highest risk and putting those resources where they need to be in that moment and not putting them where they don't need to be, kind of thing. So that's been going on for quite some time, and it did very different kind of patient and population specific use cases for that. The policy, and I agree, here in Maine, we need to make sure that these things are working hand in hand to best leverage opportunities for rural, the telehealth and digital health solutions and the AI. But again, it goes back to the barrier of who can afford to use these integrated tools, and making sure that for those communities who may not be able to use them, how do we, or afford them, how do we make sure that they're getting access to it so that we're not exacerbating inequities? And that's always a risk, I guess, of the technology, if there's not adequate and affordable connectivity and software solutions, AI solutions that are available to everybody equally. I think that's really important. And then I'll just say, before Dan and hops in, we've got to continue to address the policy issues with telehealth, or the barriers to it. And I would assume that we'll start to see some policy or legal and regulatory issues arise within the AI space as well. So how do we proactively address those as a state, in the absence of like, we can be the solution driven folks that are driving, hopefully, the federal policy moving forward, versus reacting to it, because it's not likely to come for quite some time.
Maybe even be prohibited for some time. We'll see. But Dan.
So knowing that our state is not in a wonderful financial position currently, this is perhaps a bit of a stretch, but why not have the state put some dollars towards innovative programs in the rural parts of the state that would provide, for example, a grant to do some remote patient monitoring for a cohort of patients that are currently, on Maine care, and see if we prevent some of those patients from being readmitted. That will probably save the state money in the end, but could serve as a really visible way in which a small investment in some of these tools could ultimately reap financial gains, not to mention benefit for the patients in terms of keeping them healthy. So basically, let's put a little bit of money where our mouths are. If we're serious about doing this, let's invest some. And again, with the idea that we're not going to solve it for every part of the state, but maybe we can have some demonstration projects, kind of like what Chris was saying before. That would be a way.
And I'll broaden that suggestion maybe a little bit to look for potential funding sources. The state and general funds could be one, and it is also a very tight budget time, and is likely to be in the coming next year and biennium. And maybe there are others. There's Danielle and I often say the whole Northern Borders Commission is just like this magic money out there that is all about rural. Maybe there's something there. We've got Carmen. Is that getting axed
I'm
too?
not so sure about
that
the
getting axed?
likelihood of that being, yeah.
Oh God. Well, anyway, others, there's other philanthropies in the state that are interested in rural health. So
And I wonder
just
about
broaden it to say,
MEHAF has this very strong focus on workforce. Could we have a conversation with them about the Mackenzie Scott funding that they have?
Innovation Fund, yeah. Peter Carmen Lucia book, looking for things next time around. So anyway, there could be others as well. But to your point, Dan, I think looking for funding to make available. I'll also put an extension on what Danielle, what you were saying, or Dan M starting the question, and Danielle about, is there sort of a natural progression from telehealth to AI? And I would say not only in adoption, but in support for. And Danielle has been a very faithful participant in many of these discussions because as director of the Northeast Telehealth Resource Center, I think both she and I think of that as potentially a way to build similar kind of supports. That's been a phenomenal support to providers in terms of learning about telehealth, implementing telehealth, ensuring safety of the implementation of telehealth. Could there be a similar kind of role around AI? And that doesn't exist federally yet, but it seems like a natural and trusted partner, because I think not only would we need funding and ideas and sort of triaging of ways that AI could be adopted, but we need technical assistance for the small and rural providers as well. So I'll just throw that out as a friendly addendum to that idea.
So
I've got a few more minutes.
I can't
Yes, Mary.
figure out how to raise my hand on my phone. Sorry about that. But I need some assistance myself, I think, sometimes. But what I was going to ask is whether we've had any luck in the state with PCORI grants, federal outcomes related research, and could we maybe, with some conversations with those folks at the national level, figure out if there is some type of state match or state investment that could be compelling in bringing federal funds to Maine as an incubator for some of these things and really being able to show outcomes. Certainly, the work that we've done with MCGI and other things shows really positive outcomes from things that are involving the sort of virtual convergence of skills and bringing in different people. And as we implement AI into that, we're thinking about how to fund that and how to continue to show the outcomes related to that. So I don't know if a match would be compelling to them or how they would like to see the sort of state federal partnership moving forward, but it might be worth a conversation.
Yeah. And I don't know, particularly Dan, Danielle, Sue, if you or Chris, research dollars in this area. I don't know. I mean, research is also not a friendly word these days, but I know there has been some PCORI funding in the state, to entities in the state in the past. I haven't really seen it in this area, but
Actually, I was just going to say PCORI. I mean, especially if the focus is on the kind of things that Bryn was talking about is, how does it affect patient experience?
Mhm.
And patients are involved, that would not be hard to accomplish. Yeah, I mean, research is tough right now. Foundations, I mean, I'm working in food and nutrition now, and huge amounts of money have coming from to do research from Rockefeller, American Heart Association. So some of the big well-funded foundations are picking up the slack.
I think the vendors, I mean, I'm not sure, you all would know better than I who the largest tech inclined service providers are, but vendors right now are investing a lot of money to improve their technology because it's a bit of an arms race to see who can have the best tools. So if we had some sort of context, maybe an RFP where we offer context, rural clinicians to be a design partner in exchange for X amount of investment to help build it out, might be appealing to certain technology companies that want to get ahead of their competition in this space. I don't know if that's easy to say. I'm sure it's easy to say and hard to do, but we do have the leverage of, we have the data, we have the patients, we have the clinicians, and that's what the tech companies don't have. They need the context through which to experiment and improve their products. So how do we use what we have as some sort of incentive to attract, whatever it is, X $1 million of investment to build a rural demonstration site around technology with the right partner?
Another interesting idea. All right. Anything else on this? What might it take? What could we do in Maine to encourage innovation before we use the last 5 minutes for a wrap up and closing up?
I just think that telehealth, just as a person who grew up in a tiny little town that had really no, if you needed anything, you went to the hospital for everything. I mean, it's got to be, telehealth has to be a big part of the solution. But I mean, obviously you all already know that, but maybe something around our recommendations that Maine could be the premier sort of place in the nation with respect to embracing telehealth solutions and setting up teams and task force to specifically push telehealth to its full potential. It sounds like you're already doing that, Danielle, but in the context of our recommendations to the governor, more investment, more sort of spotlight, more call to partner and participation, specifically around telehealth, might allow us to build something and find innovations that other states would be, eager to learn from and could position us in the forefront, including on patient participation and clinician participation in the ways that Susan and Bryn have been advising us today.
Mm-hmm. No, absolutely. And I think if we could pilot some of the, as we were just talking about, an RPM solution, for example, that addresses a key issue, cardiovascular, prenatal. We could look at lots of different things. We could take a look at our data, Maine Care data, for example, to inform what we thought we might want to recommend for potential pilots. And then, maybe we go to the American Heart Stroke Association Foundation and partner with them on specific pilots that really truly integrate AI into telehealth solutions, and study the impact of that.
I really love this idea. I think it is exactly the right thing to do and to be at the forefront. And I'll just ask, just because I'm not clear on this, and I think it's both a potential hurdle and an opportunity, but do we feel like we have the technology penetration, the sort of coverage in all these areas to expand programs and really be successful? And if we have limitations, are there clever ways to get beyond the sort of infrastructure limitations that we could use in terms of how the AI is implemented or where it's implemented or how it's distributed, to areas that are rural? Because I think that overall this is going to be a big problem nationwide in rural areas about the ability to just get cell phone coverage, about getting internet access, getting the systems to work reliably, for people to not be annoyed with intermittent crashes or call drops and things like that. And so I'm just wondering if there's a way that we could really lead in resolving that as well, and not fall victim to it if we set this goal and have it trip us up.
Well, I mean, just briefly, and it's, maybe not politically the right idea at the moment, but Starlink is the transcendent solution, but there are increasingly more and more Starlink competitors. So I just think the connectivity issue, we're living through the worst it's ever going to be. It's only going to get massively better as more and more competitors, and Starlink, setting aside the politics of that company, it's a game changer for the whole world in terms of its ability to connect the world. And increasingly the competitors there. So maybe leaping ahead to embrace satellite technologies as opposed to trying to continue to push the rock uphill with AT&T to get cell coverage expanded throughout the state. Might be part of the way to do that.
Yeah, I do think that there's going to be, with like the changes in the BEAD sort of guidelines and requirements for infrastructure. And Maine is a leader in how quickly we have distributed our infrastructure dollars for sure, which has been great with all of the changes. But all of us are kind of in the same boat with respect to the digital equity and inclusion. We just had a big strategy meeting earlier this week to say, oh my gosh, how do we sort of reprioritize and fund things that we think absolutely must happen in the absence of these $35 million that Maine was allocated. Of course, we're participating in the legal battle to hopefully reinstate it, but that could take months or years. So we're working on contingency planning, but I do think we have to have our ISPs, our cellular, our satellite partners at the table as we're starting to develop these solutions, because if they don't know that they should be, or it's not on their radar or prioritized for them, they won't necessarily do it. Healthcare isn't always their first area of concern. They've got lots of folks who are kind of pushing them.
So we are going to have to wrap. I'm sorry, we are at almost time here. So a lot of great discussion ideas. Thank you so much. I think in terms of action steps, clearly we will be summarizing the discussion. I said Dan was offering to do it in the background. I said after the last meeting, I had, I think, 2 different people send me AI generated meeting summaries. So thanks for that in advance. Anybody else who's doing it today? And then I think trying to pull out some of these key, the start of recommendations for these 3 questions, which will continue the discussion at the 3rd and last meeting of this group coming up in just under a month. So Friday, July 18. A Friday, July meeting sounds dangerous, but I'm going to hope that the majority of the group is around an afternoon even. That's awesome. But if you're not, please let me know so that we have a good and meaningful 3rd discussion. But with that, Dan, Matz, anything for the good of the order?
Nope, all set.
Okay, super. Well, thanks again, everybody. Thanks so much, Sue and Bryn, for joining with those additional perspectives, and everybody else. We'll see you next time. Thanks.
Thank
Bye-bye.
you.
Take care, everybody.
Everyone.
Thank you.